Good afternoon, everyone, and welcome to the webinar on the IHI Call 6, Topic 1, on support healthcare system resilience through a focus on persistency in the treatment of chronic diseases. My name is Nassima, and I'm going to be your moderator today. And just before we start, I would like to give you some information. So as usual, we are recording this webinar, and the recording and the slide will be published on the IHI website and the B2Match platform by the end of the day. The call has been launched officially today, and all the links and details of how to apply have been published on the IHI website and the Funding and Funders portal. You can find the link here below. Also, if you have any question, please address them in the chat box of the B2Match platform, and we will address them at the end of the presentation. Today, we have a few people online. So we have Calliope, who is the scientific officer for this topic, and she's going to start the presentation. But we also have Matthias Mühlenborn from Novo Nordisk, who is going to present the topic itself. And we also have Carolina, a colleague of mine, who is legal officer. So now let's start this presentation, and I will hand over to Calliope.
Yes, good afternoon, everyone, and welcome to this webinar. Today's webinar will take you through a quick introduction of IHI and the evaluation process. And then, as my colleague Nassima said, the topic writer will present the topic text. So we will not be covering the rules and procedures. For any questions or information related to these, please view the webinar available on the link below in the slide. So, what is IHI? So IHI is a successor of IMI2. It is a public-private partnership for health research and innovation between the EU, represented by the European Commission, and Europe's life science industries, represented by COSIR, FPA, Europa Bio, and MedTech Europe. At IHI, our goals are to translate health research and innovation into tangible benefits for patients and society, and also ensure that Europe remains at the cutting edge of interdisciplinary, sustainable, and patient-centric health research. And health research and care increasingly involves diverse sectors. So by supporting projects that bring these sectors together, we hope to pave the way for a more integrated approach to healthcare, covering prevention, diagnosis, treatment, and disease management. So our projects are created via open and competitive calls for proposals. And each project in itself should be cross-sectorial, as is our program. That means it should include both public and private partners. The private partners, which are affiliated to the industry associations of IHI, contribute to the projects mainly in kind, and the European Commission provides the public side of the funding. So how does it work in practice? So we have both single stage and two-stage calls under IHI. So this specific call is a two-stage call. And what does it mean? So illustrating here the process, it is the industrial partners that prepared the topic text. So they drafted the text and indicated the contributions that are coming from the industry side. This topic text prepared by the industry is launched as a call for proposals. During the call for proposals, the industry consortium who prepared the topic definition and the topic text step aside, and we open the call for the applicants applying for the public funding only. These are typically academics, hospitals, SMEs, patient organizations, and so on. So at this stage, stage 1, consortia applying for the public funding form and submit short proposals that are meeting the requirements of the topic text. So as you can guess, at this stage, there are multiple consortia formed and multiple proposals submitted. So once you put your consortium together, you write your proposal together, and then you submit the proposal by the designated deadline of 16th of April, these proposals will go through a round of evaluations by independent experts. So we only take the top ranked proposal, so one consortium only following this evaluation, and we invite that applicant consortium to the second stage. At the second stage, the successful applicant consortium will merge with the original industry consortium, and they will work together to prepare the full proposal. The full proposal will then also go through an evaluation by an independent panel of experts, and with a go, no go decision, the project will or will not receive funding at the end. So this is it from me for now. I'm happy to give the floor to the topic writer, who will present now the topic itself. Thank you.
Yes, hello. Thank you, Calliope and Nassima, for the introduction. And actually, I will give the word to my colleague, Gunnar Radziskowski, who will go through the topic text and present on behalf of Novo Nordisk.
Thank you very much. So good afternoon, everybody. My name is Gunnar Radziskowski, and I am from the medical affairs part of the organization. So just before starting introducing the project proposal, one thing that I would like to sort of introduce is the definition of treatment persistency. So what you have in the middle is a simple figure, and you can see the source down at the bottom, what treatment adherence is. So persistency is part of treatment adherence. So on the top, you have the compliance. So that could be measured as percentage of doses taken as prescribed. And then persistency is the time from starting the medication until ending the medication. So what we would like to focus in this project is the cases where people with a chronic disease are stopping the medication before time, and what is it that this is happening. Next slide, please. So the challenge we are facing, this is divided sort of in two parts. At the left part, we have the group numbers. We know from several analyses that half of the patients living with a chronic disease will discontinue treatment within the first 12 months. We also know that the healthcare ecosystem is sort of having a hard time. There's an increased burden in the health system, and we can see from different analysis that 1/3 of the primary care physicians are burning out. Whether these two sort of data are interconnected, we don't know for sure, but there's at least some kind of connection here. The other number is that, and this is where patients' lives really matter, is that living with a chronic disease, and here we have an example of type 2 diabetes, not being on treatment will lead to devastating and expensive complications such as cardiovascular disease, kidney failure, blindness, and at the end of the day, premature mortality. So the question that we're having is that although that there are many new medications, there are many sort of new forms of technologies being developed, how come that we are not able to keep the patients on treatment? An ideal situation, as depicted to the right, could be that we have a digital tool that can help to diagnose. You go into selecting a treatment. This will then lead to hopefully achieving goals and feeling healthy. Results can be shared with doctor. And then you are being sort of kept in this loop with improved treatment as long as so during your condition. The interesting part here is that how can we also, in case of a patient stops the treatment, either by going on vacation or just don't feel taking the medication, get them back into the healthy green loop, back to the right medication as needed. So looking at these numbers and how we sort of foresee things might happen. Next slide, please. There are barriers, and this is just also to emphasize that this is not a new theme. This has been studied for years, and as very nicely reviewed by Cranstrom et al. From 2021, there are certain barriers around treatment persistency. These are sort of divided into different categories. There are patient-specific. It could be lack of knowledge, lack of routine, or any other kind of factors having effect, socioeconomic background. Disease-specific, we see that a lot. The disease can have lack of symptoms, lack of improvement. Treatment-specific, so some are not tolerating different medication. Then there's the healthcare and system specific. This might sort of tie back to 1/3 of the healthcare professionals or the primary care doctors are burned out. How is this communication happening? What is it that they're communicating with? And I will give an example later on. Social and cultural specific, and finally logistic and financial specific barriers. Next slide, please. So why do we need a public-private partnership in order to understand this? So we are sort of acknowledging that the ecosystem is transforming. With the new knowledge that we get from both academia and the private sector is that we are moving from a drug-centric offering to a more sort of integrated ecosystem. And here we have both the digital tool, but we also have the options of giving different kind of medication depending on the patient profile. But what is the situation? The situation is that the healthcare system is sort of on immense pressure. And we also have scientific organizations that are sort of pushing for having a much better ecosystem in order to keep patients on the medication that they are being prescribed to. And at bottom line, part of the situation is that patients do not fully benefit from the available treatments. And it doesn't necessarily have to be the new modern ones. This is also talking about the older medications that are now off patent and easily affordable that patients are not staying on. So what we want when building this public-private partnership is to set some questions around treatment persistency or lack of persistency. Is why do people actually drop off chronic treatment? Which healthcare ecosystem is actually excelling in this, and how can we learn from these ecosystems and bring that into the projects? We need to identify the stakeholders who are important in this communication and help to improve the persistency in this manner. And a basic question, how can we sort of leverage or bring forward synergies in a public-private collaboration and improve the treatment persistency? And finally, what are the key gaps that is maybe going further steps back? What are the key gaps that we have in order to improve treatment persistency? Is it technological, scientific? Is it practical or commercial key gaps that needs to be addressed? Next slide, please. So looking at the scope, we have sort of divided scope into two core beliefs. The first one is sort of bringing forward that a collaboration among the different stakeholders is highly warranted. And in the middle, you see the man and the green symbols around him is a number of stakeholders. And this is just to bring examples on what kind of challenges and wishes there are from the different stakeholders. The HCP, this is a statement from HCP saying that most of the time during a consultation is used to ask whether the patient is taking his medicine or not. So how can we improve that communication and instead talking about whether you are taking the medication, then talking about how it goes with treatment and what the results are. Then we also have payers and the healthcare system, and also guideline people that are making the guidelines. Here there's a sort of a wish or a need to improve the persistency. We know from at least diabetes that there is low rates of adhering to the medication. Next slide, please. And part of the project is sort of to gather the clinical evidence that we have so far, so connecting all the dots with regards to those that have data available. And the sort of the methodology around it is get the data, figure out how to test whether we can improve the persistency, evaluate it, implement it if possible, then test it again. And what we want out of this is to use observational and diverse clinical research methodologies to demonstrate the impact. It should be drive fit for purpose studies. And here we would like to emphasize that the scalability of such new ideas that are coming up, or how we can scale already existing ideas, is very important for this project. Foster close collaboration with academic expertise, and then finally, if possible, try to build these internal understanding and have them as a guiding framework on how treatment persistency can be improved. Next slide, please. So from these scopes and methodologies, what we expect of outcome is that we are able to map and share insights from existing projects and data set, and these will then be used to try to implement and upscale how we can improve treatment persistency. Develop and implement new ways of working together with public and private organizations with the aim of improving persistency and health outcomes. Of course, a part of this is to generate clinical and scientific evidence to demonstrate the results on these new approaches. Integrate them into the daily practice by developing consistent methodology and framework for measuring persistency. And then this is also a wish, if possible, develop recommendations and consensus reports on how relevant healthcare stakeholders can be sort of improving the treatment persistency. Next slide, please. So the expected impact, and that is sort of to sum up what we expect. But before that is just to show what our view is on this project, symbolized as the green one in the middle, treatment persistency. So we would like to learn from already existing projects, and one example is the Swedish telehealth, where you are basically receiving an SMS whether you are taking your medication or not. So what were the learnings from there? There are ongoing IHI projects, the BEMA project, where they are looking at patient behavior and drug adherence. how can these data and learnings be implemented into this project? And then there are ongoing projects from the industry. We have in Novo Nordisk ongoing projects, Microsoft have, and how can we take these learnings into the project? And what we hope we can have an impact on is to improve the outcome of patients with chronic disease by supporting them to stay on the recommended and most relevant treatment. And that will hopefully lead to less comorbidities and thereby reducing cost and inefficiencies in the healthcare system. Next slide, please. So the contribution from the industry, here you can see the ones that have already said yes to this project. It's Abbott, Eli Lilly, Menarini, Novo Nordisk, Pfizer, Sanofi, and Severe. They all will contribute to the project, and the contribution will be results and insights from existing pilots, as just mentioned, real-world evidence and clinical trial data that many of these companies are possessing, expertise in medical science, data collection, and all other kinds of input, data platforms, digital tool, apps, and remote monitoring technology. So this is the in-kind contribution that is expected. Next slide. What is expected from the applicants is the project is scoped around diabetes, obesity, and the related comorbidities. So having experience and insight from these diseases will be key. It's expected from the applicants to sort of be able to drive observation and diverse clinical research studies to demonstrate impact, including having eyes on health economics, be able to design fit for purpose studies to secure the evidence needed to maximize the impact. So since this is a public-private partnership, close collaboration with the industry and academia to ensure a sort of fast and feasible execution of real-world settings. Ideally, when all these data are collected and insights, how to build and understand the competencies within persistency and inform other peers in the healthcare system to further build and train programs in the healthcare. Analyze how the new learnings might be implemented in clinical treatment guidelines, and then access to relevant data and persistency and treatment, such as access to electronic records, is important. And finally, expertise in patient journey, clinical practice, and chronic disease management. Next slide, please. So the budget is coming from IHI and the in-kind contribution from the industry, 11.3 million euros each. And next slide. And the duration is expected to be 5 years. And with that, thank you for your attention.
Thank you very much. Now I will take back the presentation and give you some more details on the proposal submission and evaluation. So the proposal template has a few parts. So part A of the proposal is where all the administrative data is, and part B of the proposal is the narrative part that includes 3 sections: excellence, impact, and implementation. And of course, there are some annexes that you should upload for this first stage is the participant type annex, What's very, very important here is that you read carefully the instructions in the proposal template. It will give you tips on what is expected. It will give you additional information to make sure that all the sections are filled in appropriately. It will give you information on the font and page limit and so on. So please, please, please read this Part B instructions very, very carefully. So in terms of the evaluation criteria, they follow the sections of the proposal template. So you will be evaluated on the excellence, impact, and implementation. What is important for you to understand is that the panel of independent experts is asked to assess you on all the points indicated in these slides. They will have to make statements on, for example, the clarity and pertinence of the project objectives, on the soundness of the proposed methodology, and so on. We therefore advise you to carefully consider these points when drafting your proposal and making sure they are all addressed. So yes, so this is the implementation questions that the experts will be asked. So some tips for you, of course. Read all the call relevant material, especially the topic text. The topic text is the document against which the experts are asked to evaluate your proposal. So it's very, very important that you address all the aspects required. Form your consortium early. Of course, the merger with the industry consortium happens only at stage 2 for the winner of the first stage, but it's important that your proposal reflects the need for a PPP to address the challenges. The fact that you will not be alone in this project and that you have understood the specificities of our programs will help you. Please, as I said earlier, ensure that all the information requested also in the proposal template have been filled in to allow the experts to easily assess your proposal against the criteria. And finally, please consider the regulatory impact of your results. As I said earlier, we are looking for impact and tangible benefits for patients and society, and this is a very, very important aspect. In the final slide of my presentation, we've put here some useful links for you to find potential interested partners to build or join a consortium. Thank you.
Thank you, Calliope. So now we will go to the question session. Please feel free to drop a question in the channel, in the chat box. Just to reinforce, this is your only opportunity to get the information directly from the topic writer, so please do so. We do have a few questions. So the first one is from Anna, and she's asking, can we also consider the non-voluntary interruption of therapy of chronically disabled patients and submit a project that allows long-term remote treatment to ensure the continuity of the care pathway? Or should we consider only persistency of drug treatment?
Sure. I mean, what I didn't make clear was that we focus very much around drug, but it's any kind of treatment. Of course, that kind of proposal will also be accepted and relevant.
Thank you. Now we have some questions received via the mailbox. So the first one is, whilst not explicitly mentioned in the focus of the grant, would the call be open to looking at chronic reproductive health illnesses such as endometriosis and cervical cancer? This is the first question.
No, I mean, what we will focus on in this project is diabetes, obesity, and the related comorbidities. Maybe we might add one more chronic disease, but at the moment, this is the focus that we are bringing forward.
Thank you. And the second one via email is, does this have to have an EU focus or can research be expanded globally?
It's probably more for you to answer from the IHI office. So the research institute should be primarily in Europe, but I leave it up to you to give a more precise answer.
We do have a follow-up question from Anna. So she's writing, but in that case, can we involve not pharmacological industries? Question mark.
So it seems like so as this was explained, this is a two-stage call. So the industry partners have been selected and they have committed to this already. So the applicant consortium is the consortium that that applies for the funding from the European Commission. That can include many other parties, but usually no big industry because or like big private partners, because that's usually not being funded in these two-stage calls. So, but small and mid-sized enterprises can come from any other areas. So if they are relevant for this topic, they can be included in the application. Yes.
Thank you, Matthias. The next one is from Ellen. How important is addressing the care continuum? Should modeling be used?
Yeah, I think
could be one of the sort of tools in order to understand the patient care. So yes, any kind of tool that might improve the treatment persistence can be helpful in this.
Thank you. I don't see any other questions so far in the chat box. Yes, Calliope?
Yes, so maybe to complement what was said about in some of these questions, as Matthias said, maybe we can complement as the office about the EU focus. Of course, IHI is a European public-private partnership. It is important to keep the focus in the EU. It can then, of course, the results can have an uptake or can be further exploited at global level, but of course we start with the EU. And something important for you to understand as applicants for the public funding is that there are some eligibility conditions as well that apply, and not every country, or not what we call third countries, actually are not cannot receive EU funding as well. So this could play, unless exceptionally considered by the independent experts, and this could play a role in you deciding to form a consortium. Another aspect as well is that, as Matthias said about the non-pharmacological industry, indeed, there is a pre-identified industry consortium that prepare the topic text, who now you decide to bring on board as part of the applicant consortium is up to you, but it has to be, of course, justified in your methodology and in building the consortium capacity. So this is what I wanted to add.
Thank you, Calliope. The next one is from Amanda. She's asking, what role do you see for patient partners on this project?
Definitely an interesting role, I would say. So we want to really cover the entire healthcare ecosystem, and the patient is, of course, a super important part of this. So definitely patient organizations, it could also be patients in the project, and participating in the research development bits is super relevant. Yes. But
in the topic test, it is mentioned that patient voice, as we call it, could as well be an enabler to some of the barriers that exist in treatment persistency. So yes, a relevant stakeholder indeed.
Perfect, thank you. Now we have Christoph writing us. As you explained very clearly, non-persistency is very multifactorial and likely varying across countries or even local ecosystem. At the end of this project, would you prefer to have local ecosystem success example to learn from, or rather a toolkit for how success could be achieved regardless of ecosystem?
Yeah, fantastic question. That's really good, and actually that's something we have missed a little bit in the presentation. So we are very well aware of that there are many different ecosystems and different tools in different geographies. So we would like to cover a number of geographies. We don't think there's a one solution for all the different systems. So we are looking indeed for a toolbox where we can pick and choose for the specific ecosystem. So yes, we want to. We probably see a couple of use cases in different geographies, and we hope to learn and share from that perspective.
Thank you. Now it's Gabriella asking, how many chronic diseases should be addressed in the proposal? This is her first question. And her second question is, what chronic disease should be on the main focus?
So what we describe in the topic test is diabetes and obesity and the related comorbidities. And here the two top comorbidities are cardiovascular disease and kidney disease or kidney failure. Those are the diseases that, but the main top diseases is diabetes and obesity.
Yeah. But there's space for a fourth disease area if that's relevant. So the predefined industry consortium is focused on diabetes, obesity, and cardiovascular disease. So those are the three diseases that we have our main experience with. So the pilots and so on, the experience that we have comes from that area. So that should be kind of guiding a little bit. But there's space for like a fourth disease area. Yeah.
Thank you. And now we have Stefan. So he's writing us. The call states that the goal is not to develop a new technology. What about to further develop an already implemented and in use in bracket technology to further improve treatment persistency in bracket implement test evaluate ?
So yes, what we also search for is already known technologies. How can we scale those? Or maybe look at it, how does it fit to different geographies? So that is also a question that we pose in this. So as much as we can learn from already existing technologies, projects, ongoing projects is highly warranted here.
Thank you. And yes, maybe we can remind to all of you to read the topic text carefully as it has the detailed information. So read it carefully. And I don't see any other question in the chat box. So if you have any, please drop them. As I said, it's your only opportunity to ask the topic writer themselves. Meanwhile, I would like to reinforce the fact to follow us on our social media. To have the latest information about the call launch, the call topic, and everything that IHI is doing. I see a new question from Amanda. Do you see mental health as a potential third chronic disease or a barrier in TX persistence or both? ?
Yeah, could be.
Could well be now that we are putting obesity up as a disease, how that is connected to mental health. Could be.
Thank you. We have a question from Ellen. Do you see a key role for digital technologies, e-health apps?
Absolutely. That will also be something that we'll be able to share from the One Nordisk, our learnings on developing apps and what kind of information we can collect and more importantly, the communication between the app provider and the app holder.
And patient level data,
Yeah,
and how we use that, and how can we share that in a safe and GDPR compliant way. So that's definitely something that's relevant for this project.
Absolutely.
Thank you. And we have Jan asking us, could the project build on results of IMI2 projects such as Rhapsody?
Yeah, absolutely. Yeah.
Yeah, go ahead.
Yes, maybe a comment for you as well is to understand that I see you have some questions for the topic writers about the diseases to be included and so on. I think what's very, very important, as I said, is to remember that this will be evaluated by an independent panel of experts who have the topic text in front of them and who will assess your proposal on the basis of what is in this topic text. So please focus if you want to put forward a disease area, make sure you have good arguments for it and that your methodology is sound. As I said, of course, Matthias and Gunnar are here to give you more insights, but ultimately the experts will evaluate the proposal. So please remember that.
Yeah, thank you, Calliope.
Thank you. Do we have any other question? I don't see any question coming in. I assume the presentation was really clear to all of them. Yeah, I think that we can end the webinar here, unless we have the last question coming in. No, I don't see anything coming in. So yes, let's wrap up this webinar. So I would like to thank you, Calliope, Matthias, and Gunnar for your presentation and answering the question. As a reminder, no, we do have a question, the last question from Anna. She's asking, in the case of digital technologies, e-health application, should we involve industry as a participating member or as a consortium member?
Yeah, it's a little bit back to the previous question, right? Of course, there is the predefined industry consortium who have already experience with e-health and digital applications, but happy to include others if necessary or relevant. So we are also aware of that the industry consortium doesn't cover the entire ecosystem. So relevant players in that field could be very useful in supplementing the predefined industry consortium. So yeah.
Yes, and if I can complement on that, you can bring in, of course, industry as part of the applicant consortium, but please check the eligibility. And for that, we advise you, as I said earlier in my presentation, to watch the rules and procedures webinar for two-stage calls, where you will have information on how to be a member, part of the consortium here, in terms of organization types and how to participate. So I think this will clarify a lot of things.
Yes, indeed. We had this webinar yesterday, so all the slides and recording are online. Now we don't have any question in the chat box. So let's wrap up this session. Thank you again. So I will thank you again, Calliope, Matthias, and Gunnar for this presentation. Thank you all for your interest in this IHI topic, and I wish you good luck for your proposal. And that's it. Let's wrap up. Thank you. Bye-bye.
Thank you.
Bye-bye.